Hi, everyone. Welcome to today's webinar. Thank you so much for joining us. Today's topic is H5N1 Updates and Considerations for Healthcare Personnel. So as a reminder, or for those of you who are new to NETEC, NETEC's mission is to set the gold standard for special pathogen preparedness and response across the health system in the United States, with the goals of driving best practices, closing knowledge gaps, and developing innovative resources. So in 2015, we recognized the national need for additional biocontainment unit beds in the wake of the 2014 through 16 Ebola outbreak and began to lay the groundwork for broader special pathogens response network. We are made up of clinicians, researchers, emergency responders, and other healthcare professionals. There's 13 regional treatment centers across the country, and you can see all of those on the map here. And together we bring our knowledge and expertise in high consequence pathogen infectious diseases to NETEC to meet the needs of the healthcare facilities, emergency responders, and researchers across the country. So NETEC helps healthcare facilities and EMS agencies prepare for special pathogen events with free and virtual on-site readiness consultations and program assessments. We offer courses and trainings for nurses, physicians, emergency responders, and other healthcare professionals, equipping them with preparedness and best practices. The Special Pathogens Research Network, which I lead, has created an infrastructure to improve readiness for conducting rapid clinical research related to special pathogens in the United States, and provides researchers with training, tools, and resources to quickly understand clinical syndromes and study effective treatments and clinical management strategies. And our newest activity, NETEC's International Partnerships and Programs, convenes representatives from around the globe to share best practices and experiences with special pathogen outbreaks with the goal of establishing strategic international collaborations to advance the US and global special pathogens preparedness. So welcome to today's webinar. Here's our agenda. We'll run through an update on H5N1 from Dr. Richard Webby. We'll look at the epidemiology and risk factors and clinical characteristics of human cases of highly pathogenic avian influenza with Dr. Tim Ueki. Then Dr. Ueki will lead us through a conversation on diagnosis and antiviral treatments of patients with H5N1 virus infection. And then finally, Dr. Srinmurthy will lead us through the clinical management of influenza, specifically around H5N1. Great, and so we'll begin with Dr. Richard Webby. He's a member of the Department of Infectious Diseases at St. Jude's Children's Research Hospital and the director of the World Health Organization Collaborating Center for the Studies on Ecology of Influenza in Animals. He has a basic research program that focuses on influenza viruses at the human-animal interface, and this work involves combining laboratory and field activities to understand the human risk posed by influenza viruses circulating in various global animal populations. Feels very relevant. So thank you so much, Dr. Webby, for joining us. And I will hand it over to you for the update.
Wonderful. Thanks, Lauren, and good morning, good afternoon, good evening, all. So what I'm going to do is give a very brief sort of summary of a little bit about the events that have gone on to sort of lead us to where we are right now. Summarize a little bit of where we are right now, and then talk a little bit about what we're looking for in terms of any evidence that this particular virus, which is very much a bird virus still, is making changes, evolving, which of course we know flu does, to something that's a little bit more risky to the human population. So next, please. So if we start off with sort of the history of H5, it all began, well, of this particular H5, it all began with detection of a highly pathogenic H5N1 influenza virus in a goose in southern China. That virus circulated in the region for a while. From a human health perspective, it really came to everyone's attention in '97 with outbreaks in live poultry markets across Hong Kong. 18 confirmed human cases in that particular outbreak, with six fatalities of those 18 confirmed cases. The virus was essentially eradicated from Hong Kong with the population of all the birds in the territory. But unfortunately, the virus was still circulating and smoldering, probably in other parts of southern China. It stayed there for a few years. Then again, in 2003, 2004, it started to spread a little, but still maintained within Southeast and Eastern Asia, again causing sort of sporadic outbreaks, the odd human infections. I think the next major sort of event in the epidemiology of this virus was a rather large infection and die-off of migratory birds in Qinghai Lake in China in 2005, and that sort of signaled the westward spread of this virus outside of Asia through into other parts of Asia, through into Europe and through into Africa, and sort of that was tended to be sort of what this virus did on a somewhat annual. And if we look here, sort of what happened post that, if we look at the top here, is sort of the number of reported poultry outbreaks to WOHA, the World Organization for Animal Health. The bottom just shows the number of sequences to modern genetic databases. For a number of years, it was kind of, I guess, in a little bit of an equilibrium. The virus was still there, but didn't cause huge outbreaks. But that about 2013, we started to see a bit of diversification in this virus. So if you look at these numbers, the 2344, the 2321s, these are essentially nomenclatures for the hemagglutinin of these viruses. And as the HA evolves, they get a new clade designation. We saw a bit of an expansion of those from 2013 to 2017. This 2344B, which is the virus that we're dealing with now, first emerged sort of late 2015. But it was really in 2021 that things started to take a change, and certainly a change for the worse, with sort of an explosion of these 2344B viruses, primarily starting in Europe. So where Europe had historically had seasonal outbreaks of H5 in their poultry populations as the migratory birds had moved through, now they were in an endemic situation with year-long activity, many different types of birds being infected. From a virologic perspective, or I guess even an epidemiologic perspective, we don't really understand what changed, but something changed. This particular virus, which had undergone some transitions of neuraminidase over the time, but it settled back into an H5N1, became highly transmissible amongst wild birds. Many more birds infected, and we move to the next slide. Next slide, sorry. Yes, thanks. And then, of course, that's, at least in my reading of the tea leaves, is what pushed this virus through into the Americas. Just so much more of it in birds in Europe, that as birds sort of mingled more in the Arctic areas, then they did spill over into America. And I think that's sort of the rest is history here. The first detection in Canada, in the eastern part of Canada, in late 2021, was subsequent spread through North America, and then a little bit later down the west coast of South America, and subsequently across the continent as well. To me, and I think this really highlights the fact that we're dealing with a different form of this virus than we have at any time over the past 20 odd years. I said the first detection is in 1996. If we look at from 1996 through to 2020, we'd had one detection, essentially one spillover from Asia into the Americas during that time period. If we look at the sequencing of the viruses that we're detecting in bird outbreaks now, we've seen at least now 5 or 6 different introductions of this virus, some from the west, some from the east, and into the Americas. So again, a good indication that this virus is very different. It's spilling over. We've seen genetic diversification with this virus, both in the Americas and Europe. And so where we are now in terms of, these are just CDC and USDA numbers, just from the US. I really want to sort of look at those arrows at the bottom in terms of where we are right now. Again, this is a little US-centric, but probably can be thought of in other parts of the world as well. So wild bird detections have dropped a little bit. So, there was a huge amount of virus in North American birds. They are developing some immunity, and studies looking out have shown quite a high seroprevalence for these viruses in bird population. I think that has driven the prevalence down, and with that drop in prevalence, Human infections, Tim will talk more about. The other worrying thing, of course, we've all heard about is these wild mammal infections, whether it be sea lions, foxes, you name it, sort of host of influenza we didn't even know could be hosts of influenza. It's these hosts that we're particularly looking at when we see infections, because it's these hosts that are probably going to supply the selective pressure to make these viruses change from being bird viruses to being something a little more infectious to humans. If we click on 2 slides. So if we look at, what are we actually looking at for indicators that these viruses that, again, I think we have to say that this is still a bird virus. But in terms of the first 3 on this slide, so the receptor binding changes, replication efficiency, and HA stabilizing mutations, these are mutations that we're aware of. So we know when we find them in viruses, we have some idea of what phenotype they impart. At least in my mind, the first receptor binding change is the most important. We know a flu virus that's adapted for birds binds a slightly different cellular receptor than those viruses are most adapted to humans. If we look at all the viruses that have been sequenced so far from this outbreak, including those from mammals, so far no evidence that we're seeing changes in the receptor binding site that would indicate a change to more human tropic viruses. Replication efficiency, again, we are actually seeing mutations in these viruses that suggest they are adapting a little bit more to mammalian cells. This is happening actually in mammals that are being infected, not so much in the birds, which makes sense. This is probably the lowest hurdle that this virus has to overcome to switch. So this is from a virologic speaking, this is a sort of low-hanging fruit for these viruses. They easily make those mutations when they do replicate themselves, and we are seeing them. The HA stabilizing mutations, we don't know as much about those. No indication at this stage as well that these viruses are introducing stabilizing mutations, which does at least correlate with transmission. The ferret transmission aspect here, this is something that's more of a risk assessment model that's done with a number of labs across the world, putting these viruses into ferrets. The ferrets are probably a best indication of a virus that has any potential to transmit from human to human. So far, and of course, this is a much lower throughput assay than sequencing, but there have been a handful of these viruses put into ferrets. Most of them do not transmit, which is good news from a human health perspective. There are some and a couple of reports in the literature of limited transmission for some of these H5 viruses, particularly some that are coming out of mammals. So that's something to keep an eye on. But I think overall right now, there's no alarm bells ringing that these viruses are changing. And I think while these viruses are maintained within bird populations, it's unlikely that there's not much selection in those bird populations for the virus to change. So idea as to while they're in birds, that's a good thing from a human health perspective, but we don't like seeing these mammal infections. Next, please. So to wrap up, as I said, these post-2021 2344B H5N1 viruses, I think I've said this a few times now, have novel properties which we don't fully understand that really fueled their spread, and they are a different beast than what we've been dealing with over the past 20 years. Worrying from a virus evolution perspective, they are sampling novel hosts. We've seen dolphin and porpoise infections with these viruses. We didn't even know those were hosts for flu, as I mentioned earlier. And the selective pressures from these hosts, we don't actually understand. And so far, there's some evidence for some mammalian adaptive markers, but the key ones haven't been seen. So these smell, look, and taste at this stage very much like I wouldn't recommend tasting them, but certainly are still avian viruses. And that's, again, one of the things why, at least currently, human risk is deemed to be low. So I'll stop there. I've got some acknowledgement on the next slide, but I think I should skip those for now. So thank you.
Thanks so much, Dr. Webby. Up next is Dr. Tim Uecki, the Chief Medical Officer in the Influenza Division at the Centers for Disease Control and Prevention and a good friend of NETEC. And he'll be discussing epidemiology, risk factors, and clinical characteristics of human cases of highly pathogenic avian influenza A. Over to you, Dr. Uecki.
Thanks, Lauren. Next slide, please. So the objectives of this session are to describe the epidemiology and risk factors for human cases of highly pathogenic avian influenza A H5N1 and to describe the clinical presentations and complications of H5N1 virus infection. Next slide. So the first time that we became aware that H5N1 virus could transmit directly from poultry to humans and actually cause human death was in 1997. Richard mentioned the outbreak in Hong Kong. The first case was identified in a child in May of 1997, followed by 17 more cases that were confirmed late in the year, November and December. Overall, 18 cases with 6 deaths. There were some serologic studies that suggested additional sporadic cases that occurred. And as Richard mentioned, Hong Kong implemented a lot of control measures, controlled that outbreak. We didn't hear much about human cases until early in 2003. And that was when there was a family of 4 from Hong Kong that traveled into southern China, Fujian province. At that time, a girl in the family died of pneumonia in Fujian. The family returned to Hong Kong. There were 2 cases confirmed in the father and a son. Father died, son survived. And then later in the year, we learned about the emergence of cases occurring in Southeast Asia and in other countries. And as Richard mentioned, there was spread through migratory waterfowl, probably people moving poultry around as well. And we had the expansion of this virus to many other regions of the world, many other countries, associated poultry outbreaks, and then associated human infections. So in the Middle East and Europe and Africa. And then we've had cases more recently in the last couple of years for the first time identified in the Americas. So overall, since 1997, there have been nearly 900 H5N1 cases that have been reported with greater than 50% case fatality proportion. 22 countries have reported cases. The majority of these cases have been have had severe pneumonia, and the vast majority of cases have been reported in young adults. There have been some pediatric cases as well, but very few cases reported worldwide since 2015, 2016. Next slide. So this is an epidemic curve of reported H5N1 cases since 1997, and you can see there's some periodicity, seasonality, and different colors correspond to different countries with cases. There was a big outbreak most recently going back to 2015 in Egypt, but really you can see very few sporadic cases since 2015, 2016. And then some of the cases into the far right of the curve in 2002 and 2003. So since January of 2022, there have been 13 cases reported as of today in 8 countries. 10 cases have been adults, 3 in children. 6 cases were severe. 2 deaths occurred, 2 cases of mild illness, and 5 cases of asymptomatic cases reported. And you can see the different countries, the 8 countries that have cases listed, and I've flagged their outcomes. As Richard has mentioned, almost all these cases have been associated with clade 2.3.4.4b viruses, which is the dominant H5N1 virus clade worldwide, circulating in wild birds, causing poultry outbreaks and some spillover to mammals and some very sporadic human infections. I'll just say that you see the red asterisks there, 2 asymptomatic poultry workers in Spain and 2 asymptomatic poultry workers in the UK. And then the US case that was identified in April of last year, that individual only reported fatigue. In these individuals, there were low levels of viral RNA detected in upper respiratory tract specimens, suggesting that they actually might not have been infected. So it's a little bit unclear. My personal feeling is that doesn't represent infection. So it's pretty clear that rare sporadic human cases are still occurring and resulting in severe illness. Next slide. So how do people, or what are the risk factors for infection? So in case control studies and in field investigations, we know that the main risk factor is exposure to infected poultry, and tends to be direct or close unprotected exposure to sick or dead poultry, direct or close unprotected exposure to well-appearing poultry. There are some duck species that can be infected without apparent signs of illness and can transmit to other ducks, other poultry species, as well as can transmit to humans. And then clearly raising backyard poultry in rural areas that were sick or died. And some people have their only source of exposure was by visiting a live poultry market where infected poultry are either sold live or slaughtered for consumption. How do people become infected? It's probably through aerosolization of contaminated material that's then inhaled into the respiratory tract. Now, what about any risk factors besides exposure to infected poultry? Well, there were 2 clusters, human clusters of cases reported in 2006 in Azerbaijan. 6 family members and 1 neighbor became ill during February to March of 2006, and 4 died. All of them had found dead wild swans and then defeathered them. Probably there was aerosolization of virus and inhalation. So there have been cases, human cases, where the source of exposure was in fact infected wild birds, not poultry. Next slide. Now, there have been some rare limited cases of non-sustained human-to-human transmission. This has occurred in households through spread from a sick case patient to a family member without poultry exposures, through prolonged unprotected close exposure. So someone taking care of a sick patient who's a family member in the household before hospitalization. Both 2nd and 3rd generation spread has been reported, meaning chicken to human or chicken to human transmission, and then it just dead end transmission. When I say blood related family members, I'm talking about siblings or a parent and children, but this is this raises the question or the possibility of genetic susceptibility. However, there's also been transmission not just in the household, and this has also occurred in blood-related family members in a hospital setting. So spread from a sick case patient to a family member who was taking care of the sick patient in the hospital. So they didn't have poultry exposure, but they did have prolonged unprotected close exposure. And then also in a hospital, this has been documented for transmission from a sick case patient to a healthcare provider without poultry exposures through prolonged unprotected close exposure. So unrelated individuals. So all of this, particularly in the healthcare setting, highlights the importance of protecting both healthcare workers as well as any family members who are going to be in the room with the case patient. Next slide. So the source of infection is not always identified. It is unknown in some cases. Just to note, Richard talked about the spillover to mammals that has occurred in a number of regions of the world, including the US. There has never been a reported case of mammal to human transmission of H5N1 viruses. But because of the wide range of both terrestrial and marine mammals that have been infected with these viruses, there is the potential for human infection from either direct or close exposure to any animal. So it's not just infected wild birds or poultry, but one has to also consider domesticated animals and wild mammals. And most of the time, these are animals that are infected are going to be sick and die. There was one travel-related case that occurred. It was a Canadian who had spent about 4 weeks in Beijing, China, returned to Canada, had illness onset on the plane, actually presented in Canada with pneumonia and meningoencephalitis and actually died, and that was in 2013. And so overall, what's really important is, we need comprehensive epidemiological and laboratory investigations, both on the public health side and animal health side, to assess potential exposures to H5N1 viruses. Next slide. So there is a wide clinical spectrum of H5N1 virus infection. It ranges from asymptomatic to fulminant critical illness. Most case finding has focused on hospitalized patients with severe pneumonia, so it's biased. However, there have been some cases of mild illness that have been identified through surveillance of close contacts of severely ill cases or through routine surveillance for influenza-like illness. And there have been probably more mild illness cases, so febrile upper respiratory tract illness reported in children than in adults. Now, what about asymptomatic infection? There have been some asymptomatic H5N1 virus infections that have been confirmed through both virologic as well as serologic confirmation. It's not many at all. You have heard about some more asymptomatic reported cases, particularly recently. My view is that some of these reported asymptomatic cases may not represent true infection. It may more likely represent transient detection of H5N1 viral particles, non-infectious, that are deposited in the upper respiratory tract. So what's the clinical presentation and disease progression? So the incubation period following poultry exposures that we know of from various studies is the mean of about 3 days, a range of about 2 to 5 days on up to 7 days. Will capture most human infections following poultry exposure. This has implications for follow-up of people and monitoring of people, but I think going out to 10 days more cautiously after exposure will capture any people who do become symptomatic. So initially, people who are symptomatic present with fever or feverishness, a non-productive cough, myalgia, malaise, headache, sore throat. They can have abdominal pain and gastrointestinal symptoms of vomiting and diarrhea, much more commonly than occur with seasonal influenza. And basically, those who do progress to severe illness tend to progress to signs and symptoms of lower respiratory tract disease, such as difficulty breathing, shortness of breath, chest pain, tachypnea. This occurs somewhere around days 4 to 6 after initial illness onset. Patients with severe disease tend to be hospitalized with pneumonia around 6 days after illness onset. At admission, they have hypoxia, signs of pneumonia. Most, but not all, have the classic triad of leukopenia, lymphopenia, mild to moderate thrombocytopenia. They have many, many different radiographic findings that basically suggest pneumonitis and pneumonia. Here are some radiographs of H5N1 cases, all with severe bilateral pneumonia. It's really a bilateral pneumonitis pneumonia. Most of these are fatal cases. On the right, top right is progression of a fatal case. And at the bottom, you can see actually a terrible chest X-ray bilateral pneumonia, but that patient survived. Next slide, and was never ventilated. So complications, pneumonia is the most common complication with progression to respiratory failure, ARDS. Of note, community-acquired secondary bacterial co-infection is quite rare in H5N1 patients, but certainly a patient who's critically ill, who's ventilated, if they're in the ICU for a long time, they are a risk. There is a risk for ventilator-associated pneumonia. Other complications that have been reported in H5N1 patients over many years include acute kidney injury, cardiac failure, sepsis, shock, DIC, multi-organ failure, respiratory and renal failure. There are some atypical complications, including encephalitis with diarrhea and pneumonia, encephalitis with obstructive hydrocephalus in a child, and meningoencephalitis with pneumonia that I mentioned. Rye syndrome with salicylate exposure was reported in the very first case in Hong Kong in 1997 in a child. Multiple case reports of spontaneous miscarriage in pregnant women. An autopsy study reported vertical transmission with evidence of infection both in the mother and in fetal lung cells. So now I'll move on to diagnosis and treatment of H5N1 patients. So the objectives of this session are to describe diagnostic testing for H5N1 virus, to describe infection prevention and control recommendations, explain antiviral treatment of patients with H5N1 virus infection. So currently available influenza assays, they're both antigen as well as molecular assays. They cannot specifically identify this virus. So basically, the tests out there that are commercially available tend to either be positive for influenza A or influenza B without distinguishing them, or many will distinguish between A and B. But basically, if the patient has H5N1 virus infection, they'll most typically just be positive for influenza A. But if the patient is positive for influenza A, you don't know whether that's a seasonal influenza A virus that's detected or another kind of novel influenza A viruses of avian or swine origin, or H5N1. So if influenza A is positive, and you do suspect H5N1 virus infection on the basis of exposure history to poultry, wild birds, mammals, or to another confirmed H5N1 patient, then you really do need subtyping and specific H5 testing. And so patients with mild disease, you should collect a nasopharyngeal swab and a combined nasal and throat swab and put those specimens into separate tubes of viral transport media. And you really need to have testing by RT-PCR for influenza A and B viruses, and that should be done at a public health laboratory. So in the US, it's at a state public health laboratory using our CDC real-time assay. Just to note that for this virus in patients with mild disease, throat swabs have higher yield to detect H5N1 viruses than nasal or nasopharyngeal swab specimens. And that is the opposite of the yield for seasonal influenza A viruses. So that's where the nasopharynx is the highest yield, then nasal and throat has the lowest yield. But in adults, particularly, throat swabs are going to have a higher sensitivity. But we recommend collecting multiple upper respiratory tract specimens. And we do recommend subtyping at a public health laboratory for H1 and H3 for influenza A positives. And then if H1 and H3 are negative, that should be subtyped for H5, and that should be done at a state or national public health laboratory in other countries, and in the US, it's at CDC. Any presumptive H5 positive results at a national public health laboratory should be confirmed at a WHO reference library or at a national public health laboratory that's qualified. In the US, CDC would confirm that. So in patients with lower respiratory tract disease, and particularly if you have an influenza A positive result and a commercial assay, same specimen should be collected. In addition, if the patient is not intubated, you should collect sputum. That should all be tested by real-time RT-PCR for subtyping of influenza A viruses. For intubated patients, you should also collect an endotracheal aspirate specimens. And all of what I mentioned for mild disease patients applies, that we want the virus subtyped if it's A positive, and if it's negative for H1 and H3, then you do need H5 typing, and those results should be confirmed at a national public health laboratory. In the US, again, it's H5. And we do really recommend for patients with severe disease to collect multiple respiratory specimens from different sites, so upper and lower respiratory tract, on multiple days for patients, if you do suspect H5N1 virus infection, to really maximize the potential for diagnosis. And what I will say, in some of the cases that have been confirmed worldwide earlier this year, and including the last patient, testing of a nasopharyngeal swab specimen was negative, and the diagnosis was made by testing a bronchoalveolar lavage fluid specimen. So patients with severe disease, you really do need to go for specimens in the lower respiratory tract. So what about infection prevention control recommendations? So H5N1 clearly is associated with severe disease, and at CDC, our recommendations is that the patient, because of the potential for close range, large droplet and small particle aerosol spread, and because of high mortality with H5N1 virus infection, the patient should be placed in an airborne infection isolation room. If that is not available, the patient should be isolated in a single patient room, place a face mask on the patient, keep the door closed, and arrange transfer to a facility that does have an airborne infection isolation room with negative pressure and HEPA filtration. We do recommend standard contact and airborne precautions. So personal protective equipment that's recommended is single-use gown, gloves, eye protection with goggles, and a fit-tested N95 respirator or equivalent or higher level of respiratory protection. So what about antiviral treatment? Just to go over, currently recommended FDA-approved antivirals for seasonal influenza. At CDC, we do recommend early treatment of high-risk persons who are outpatients as well as hospitalized patients. And so all of these drugs that I'm going to talk about have demonstrated efficacy in randomized controlled, placebo-controlled trials for early treatment within 2 days after illness onset in outpatients with uncomplicated seasonal influenza. They include the neuraminidase inhibitors, oseltamivir, which is administered orally twice daily for 5 days, inhaled zanamivir, which is administered twice daily times 5 days, and intravenous peramivir, which is a single dose IV infusion. The other class of drugs is the cap-dependent endonuclease inhibitor, which is baloxavir or marboxil. We refer to that as baloxavir. It is an oral drug. It is single dose. And they do, all these drugs have somewhat different contraindications and approved age groups, as well as different adverse events. So I would refer you to the CDC web pages for more information on these antiviral drugs. So just to mention about chemoprophylaxis, we do recommend considering post-exposure antiviral chemoprophylaxis based upon clinical judgment if it has been less than 2 days from unprotected exposure or a breach in PPE. So without respiratory or eye protection based on duration of exposure, known infectious status of the birds, or exposure to a sick confirmed patient with H5N1 virus infection. If you do initiate post-exposure antiviral chemoprophylaxis, we do recommend using treatment dosing with oseltamivir. So not once daily prophylaxis, but twice daily treatment for 5 days. And that's for avian influenza viruses associated with severe disease such as H5N1. So for treatment, we do recommend starting oseltamivir or another neuraminidase inhibitor empirically as soon as possible for novel influenza A viruses associated with severe disease based on history of exposure. So certainly that's for suspected H5N1. We do recommend oseltamivir for progressive or severe disease in outpatients, and especially for hospitalized patients as soon as possible. We do recommend standard treatment dosing for patients with mild disease. However, for hospitalized patients, the optimal duration of treatment is not known. We do recommend considering longer durations such as 10 days. There are no clinical trials of oseltamivir treatment in H5N1 patients. We only have observational studies. We have multiple, I would say, limited observational studies, cohort studies, and by and large, they all point the same direction. So starting oseltamivir soon after illness onset, particularly in the first 2 days, is associated with greater survival versus later initiation of treatment. And there is benefit in some of these studies up to 5 or 6 days after illness onset. So you really want to initiate treatment as soon as possible, even if you have not confirmed H5N1, but you just suspect it. Now, there are a few case reports of emergence of oseltamivir resistance during treatment, and including with fatal outcomes. So I'll just have to say that that's all with oseltamivir monotherapy. We have no data for baloxavir treatment of H5N1 patients. So we do not recommend baloxavir monotherapy for treatment. There are animal data, and certainly there's abundant baloxavir treatment data for outpatients with seasonal influenza. One could certainly, we do need clinical trials of combination antiviral treatment, including oseltamivir and baloxavir, but actually, because baloxavir is single dose, probably one would need multiple doses, and we just don't know the right dosing of that drug. So no data for now. And I'll just say that For the most part, there are no known markers of resistance to any of these recommended antivirals in circulating H5N1 viruses in birds or that have been detected in mammals or humans. So, clearly ongoing surveillance is needed. But right now, there's no indication, and certainly in any of the human cases reported since early 2002, none of them have had any evidence of resistance to oseltamivir or any of the other antivirals I mentioned. Next slide, please. So what is the pathogenesis in those with severe disease? Generally, infection of the respiratory tract, particularly in adults, preferential infection of the lower respiratory tract leads to high viral levels and induces a dysregulated host inflammatory response. We do know that high viral respiratory tract levels is associated with fatal outcomes. There is high levels of pro-inflammatory cytokines and chemokines that basically cause diffuse alveolar damage, pulmonary injury, and multi-organ injury. We do know from a variety of case reports that there is potential for extrapulmonary viral dissemination, so true viremia can occur. We know that viral RNA has been detected in blood, serum, and plasma. H5N1 viral antigens or nucleic acids have been detected in brain tissue, placenta, as well as in the intestinal tract and bone marrow. And the virus has actually been isolated from both upper and lower respiratory tract specimens, but as well from blood, serum, and plasma, rectal swab and fecal specimens, and from cerebral spinal fluid. So true viremia and viral extrapulmonary dissemination does occur. And there have been some reports of reactive hemophagocytosis with lymphoid depletion. So just a last word about adjunctive therapy. For corticosteroids, which a number of patients have been treated with, in general, it's best to avoid moderate to high dose corticosteroids because they tend to be associated with prolonged viral shedding, both in seasonal influenza and with H5N1 patients and other patients severely ill with avian influenza, other avian influenza virus infections. And these viruses, if you use moderate to high dose corticosteroids, this may increase the risk for ventilator-associated pneumonia and either infection with gram-negative resistant bacteria, fungal pathogens, and may predispose to death. What about other immunomodulators, such as been used for severe COVID-19? We actually have no data for IL-6 receptor blockers, Janus kinase inhibitors, or other immunomodulators in H5N1 patients. It's definitely an area where we need data from clinical trials, actually of seasonal influenza, as well as for H5N1 patients. Next slide. And with that, I'll turn it over to Dr. Murthy. Thank you.
Thanks, Dr. Yaki. Up next is Dr. Shrin Murthy, a pediatric intensivist and infectious disease physician and clinical scientist at the University of British Columbia in Vancouver, where he focuses on optimizing the management of patients with severe infections. And we'll focus here on the clinical management of influenza, the H5N1 edition. Over to you, Shrin.
Thanks, Lauren, and thanks all. I acknowledge the time, and so I'm going to zip through things because I think we have some great questions in the chat. I put this slide up. It's an Osler quote, mostly because I personally have not seen an H5N1 case clinically in my units anywhere I've worked. I've talked to colleagues all around the world who have managed H5N1 cases, but this is mostly from those conversations, not necessarily from my direct experience. And so if an H5N1 case comes to your unit, there will be a lot of active learning that you will have to do in real time. And so our objectives: quickly review clinical manifestations. Dr. Ueki just spoke briefly on that, and so I'm not going to spend a lot of time there. I'll discuss supportive care strategies for hospitalized adults and kids with H5N1 and discuss what critical evidence gaps need to be filled so that we can prepare for a future outbreak. So, as Dr. Ueki mentioned, broad set of clinical manifestations, mildly symptomatic disease all the way through to life-threatening illness. And with that spectrum of illness, it becomes very challenging to implement standard care protocols and standard guidelines, given the diversity of patients that could have disease and the types of different diseases that have happened. Prior outbreaks, as Dr. Ueki mentioned, there's been very small kids, young adults primarily, with severe disease, and so something to flag, not necessarily the age distribution we've seen with other influenza or COVID-19 viral outbreaks. And like other flu types, there are lots of systemic manifestations that aren't just pulmonary: gastrointestinal, neurologic, cardiac, and multi-system manifestations. Primarily, lots of reports of neurologic manifestations. However, obviously, given the ascertainment of cases in hospitals and so on, that's likely biased in terms of the overall proportion of cases that have that. And so broadly, I like to break things down as a clinician into syndromes. Patients with H5N1, from the data that's out there, have severe acute respiratory infection largely. They'll have features of sepsis, which is suspected or proven infection with organ dysfunction. They'll have features of ARDS with acute onset hypoxemia with bilateral infiltrates. And so the management of these patients is going to depend where on that sort of Venn diagram of cases of syndrome, that they end up having. And so we do have a lot of information out there about how to manage about how to manage sepsis, about how to manage ARDS. And like the early days of COVID-19, applying those best practices to a new and emerging disease is what's recommended for influenza. So on top of the antiviral approaches that Dr. Ueki mentioned and the specific flu management, the supportive care, I always am here to talk about supportive care and clinical management for emerging infections, cannot be overemphasized as to how important good guideline adherent care needs to be. Obviously, I don't have time to go into each of the individual SARI, sepsis, and ARDS guidelines, because that's a whole separate talk unto itself. But remember that that data does exist, and to incorporate that into your care protocols for influenza H5N1. Like I said, it's going to be an overlapping picture. Patients can be in the middle. Patients can be with one of those syndromes, not necessarily all of them. And so thinking about how to manage each of those syndromes supportively during your protocol development phase. In the interest of time, you guys know how to administer oxygen and how and what different types of oxygen are. And so I'm going to skip the next couple of slides. Non-invasive ventilation, there was some concern initially about aerosolization of different viruses based on non-invasive ventilation, but given our experiences with non-invasive across different pathogens, there's more familiarity and comfort with this in management as long as appropriate PPE is in place. And so this is now becoming standard care across the world for emerging pathogens as well. Sepsis, there's lots of algorithms for sepsis. These are sepsis algorithms for children, but there are also algorithms for adults. There are surviving sepsis campaign guidelines that get updated every number of years. And these are more than applicable to the patient who comes into your unit with H5N1 or a suspected H5N1. And so acknowledging that they will be very sick and managing them supportively with the appropriate types of fluids, the appropriate amounts of fluids, and the appropriate hemodynamic support accordingly. And then lung protective ventilation and ARDS management. Many folks on this call who manage very sick patients will know these things, but applying those principles once again to these very sick patients. Kids, as a pediatric intensivist, I always like to say kids are different than adults in many ways, and H5N1 is no different, both in terms of disease pathogenesis as well as supportive care strategies. And so all of the airway, breathing, circulation issues that emerge, we have to consider. And next, managing pain, agitation, delirium in these patients. There's been lots of reports about neurologic manifestations, specifically in influenza H5N1. And so acknowledging that focusing on neurological syndromes is going to be important for these patients. We have a lot of guidance for COVID-19. Lots of great studies have been done. We do not have that guidance for influenza H5N1 or even influenza subseasonal disease in terms of the numbers of available treatments available and the quality of the evidence. And so while people may want to reach for COVID-19 guidance to apply it to influenza, it's not applicable, and we have to sort of generate in these next couple of years the appropriate evidence base. And that means all sorts of questions, as Dr. Uyeki mentioned, such as, do steroids work? What immunomodulators to work? What combination of antivirals work? We have biologic plausibility for all of the antivirals that Dr. Uyeki mentions, but it would be great to have clinical studies. Are anticoagulants necessary? How do we ventilate these patients? How do we give them fluids? And how do we expedite viral clearance for infection control purposes? Because I think that's a primary question. And overall, what is the best infection control strategy for this pathogen? And clinically, I think that's going to be an emerging question that we really have to spend a lot of time thinking about right now. I'll stop there. I'll hand it over to Lauren to moderate some Q&A.
Great, thanks so much. So now we'll just invite all of our panelists back. And as a reminder, if we run up against the clock, please don't forget to click the links to move to your evaluation for getting your CE. So maybe the first question over to Rich from Paul Unsworth. Is there any concern that super pigs from Canada pose a special risk, given that they have been documented to eat waterfowl?
Yeah, so I will admit I had to Google super pigs, but I think we can talk about sort of wild pigs in sort of the same vein as a lot of these other wild mammal species. I think if they do ingest a large enough dose of virus, they can become infected. Swine, of course, and pigs are a little bit more sort of intrinsically linked to the ecology of influenza. We know that replication of swine does drive a virus closer to being able to replicate in humans in most cases. There have been some evidence talking about swine more generally here, some serologic evidence, I think from Italy, that there have been pigs infected. There have been experimental studies that have been done. And I think luckily from that, it does look like pigs are relatively resistant to infection with H5 viruses in general, including this one. So I think that's a good thing. But again, I think if you give any mammal a high enough dose of this virus, they probably will get infection, but probably unlikely to transmit from that host unless changes occur in that infection. Over.
Great, thanks, Richard. Maybe over to Tim, a question here in the chat from, you mentioned considering post-exposure prophylaxis after exposure. Was that for all unprotected exposure, even in the absence of symptoms of infection?
So really, we're talking about people who had a very concerning exposure to H5N1. So what do I mean by that? It's not someone who just walked into a backyard where there were sick backyard birds or dead birds. It's not someone who was out and saw, dead wild mammals or dead wild birds, or even, were very close to them. So it really would be someone who's having pretty long exposure, unprotected exposure. So most typically lack of respiratory protection. So someone, let's say a lot of poultry died on a farm, and for some reason the person was just, being exposed, handling birds. Virus might have been isolated. If it's a confirmed outbreak, yeah, that kind of person, I would initiate a post-exposure treatment. We call it chemoprophylaxis, but as I mentioned, I would use a treatment dose twice daily for 5 days, but I'd monitor that person. So here we're talking about post-exposure. We're not talking about symptomatic people who then are treated. We do recommend monitoring people who have been exposed either through occupational exposures or recreational exposures for 10 days. Public health should be monitoring that. It's typically local public health in association with state public health. And people should self-monitor. If they develop any kind of symptoms, they should report that, and those kind of people should be tested. I'll just mention that we have followed, along with our local and state public health partners in the U.S., more than 6,000 people, and there've only been a little more than 160 people that were symptomatic and were tested. And of those, we only had one positive. And that was someone who I actually don't believe was truly infected at all. That person was not compliant fully with all their PPE. They were helping depopulate poultry in a confirmed H5N1 outbreak in poultry. So in general, you want to monitor people that were exposed, unless it's a really strong exposure, prolonged exposure. I probably would not initiate post-exposure treatment, prophylaxis, which is really treatment. Thanks.
Great, thanks, Tim. And we are coming up on time. I'll maybe hand out one great question from Miriam and put a little piece of it on my own as well. So there's tons of great questions in the chat, but given, all the issues that we saw related to public health messaging around COVID, our CDC, WHO, and even other partners working to improve effective public health messaging for avian flu. And I think a follow-on question to that is, are there things that we can take, steps that we can take to support the messaging around how we manage avian influenza, especially thinking that we're not in a typical flu season right now. So on the human side, if these patients come through our emergency departments, we may not catch them right away.
Well, I'll defer the CDC specific things to Dr. Uyeki, but I agree that this misinformation and public health communication is going to be the biggest challenge going forward, not just during seasonal flu seasons, but during a potential outbreak in the future. And are people working on this? Yes, I think many folks are thinking how to best communicate complex messages with lots of uncertainty to the public. And as everyone knows, it's not easy.
Yeah, I'd just add that I think CDC, we believe the public health risk is low from this virus. The perspective is quite different from our agricultural colleagues. This is quite a threat to domestic poultry production. The virus is, as Dr. Webby has indicated, it's pretty prevalent in wild birds worldwide. It's not just a US or North American phenomenon. So this virus is not going away anytime soon. And as we know, it's spread to South America and causing outbreaks in wild birds there, as well as now some poultry outbreaks. And there have been human infections in one case in Ecuador and one case in Chile reported. So I think we've got to pay attention, but overall, the public health risk is quite low. So we need to know, we really need people not to panic. But there are certain precautions to take. We do not recommend handling sick or dead wild birds or sick or dead mammals or sick or dead poultry without respiratory protection, ideally. So people should tend to avoid those and report those to the animal authorities.
Great, thanks. And I think I will just throw one more question out there for you, Dr. Webby. There's a question about the risk of wild versus domestic animals, given the recent report of H5N1 being detected in cats, even domestic cats in Poland.
Yeah, so quickly, I see Tim was typing an answer to that too, but I think, quickly, this virus is still very poorly infectious for humans, but the more chance there are for exposure of humans to an infected animal, clearly that increases what is a low risk. So yeah, I think when we're seeing more of perhaps these domesticated species infected, that does increase a potential exposure, so therefore does increase the risk sort of by definition. So I think it is sort of a worrying recent event and sort of the epidemiology of this thing, and we're sort of watching that closely to see what it really means, which at this stage I think is, when I say that I mean the H5 in cats in Poland, but it's a little unclear exactly what's going on there.
Great, thank you. So I think with that, we've come up on our time and then gone over a bit. As a reminder, NETEC is here to help. We have tons of resources on our website at netec.org. We also have a space where you can submit technical assistance requests or send questions to us. We continue to build resources and develop online education, and it's available for you at 24/7 on our website at netec.org. Here are all of the ways you can join in the conversations with us. We are very active on social media. We have a ton of resources in our resource library, and our SMEs are ready and willing to assist you with any of your questions or concerns through our email at info@netec.org. I would like to just give a second thanks to our To our distinguished speakers, it's been incredible to hear from you all. I think H5N1 is at the forefront of all of our minds, as if we don't have enough infectious disease threats to worry about. We continue to see cases in animals, pop up and continue to be vigilant in observing those cases. We really appreciate all the time and effort you gave to us today. As a reminder, the information that we shared today will be up and available on our website, and we will see you next time at our next NETEC webinar.